Again, welcome everyone. I think a lot of people have joined since I welcomed everyone to our September Tobacco-Free Tuesdays webinar. We have a very exciting program today. Excited to have Jim Pavlik here, and I will introduce him in a little bit. Again, just excited to be here and with you on this September day. We have, again, put everything you love about fall in the chat and your name. Thursday, I know everybody knows what Thursday is, September the 22nd, first day of fall. So we are right in it, moving on toward winter. So we're just, again, really excited to be here. I'm going to go ahead and get started. I know several people will continue to come in to the presentation, but we have a full agenda today, and I think it'll be an exciting time with our host to really learn more about behavioral health and tobacco. And as all of you know on this call, such an important topic that we will be discussing today. So I will go ahead and get started. You all know, if you are familiar with this webinar, that we do a tobacco T. What's the T question? To just learn a little bit more about what you know about tobacco. And the question today, you know, everyone needs to be healthy, and we are really promoting those environments that provide those systems in place, that provide treatment, that provides normalization for tobacco-free environments. And this question I wanted to put up for everyone to take a look at. As of January 15th, 2022, how many states require tobacco dependency treatment in substance use treatment facilities? You have 0, 5, 10, 25, and 40. So again, this is nationwide. How many states require that? Take a couple more seconds, submit your answer, and we'll see what you think. Zero, 23%, some 41% said 10. And the true answer is 5, 18%. So only 5 have the required tobacco dependency treatment in substance use treatment facilities. Does anybody have any idea of which states do that? And if you do, just put some states in the chat. I will give you a hint that Virginia is not one of them. And someone said to me earlier, of course. So which 5 states actually have require tobacco dependency treatment in their substance use treatment? California, New York. These are some guesses. I'll tell you the answers in a little bit. Any other guesses? Minnesota, okay, I saw that one too. The answers are, those 5 states are Maryland, Massachusetts, New York, Oklahoma, and Oregon. So those are the 5 states that require that. Even fewer states require tobacco dependency treatment be included in the clinical practice of mental health facilities, and they're Alabama, Maryland, and Oregon. So I think, you know, we do, and the regional coordinators in the Virginia Tobacco Control Program has, you know, this is a priority to really work with our behavioral health facilities to get them to implement voluntary policies, whether it's the treatment policies in their facilities or the tobacco-free policies. So it's something that is a priority for us to work with, as I know many of you on the call too. So I'm going to get right to our program today. So excited to have Jim Pavlik here with us. I think you're going to be thrilled with this presentation. He's got so much good, relevant information that we can use as a state and in each of our local communities. Jim Pavlik is the Senior Program and Policy Analyst for the Behavioral Health and Wellness Program at the University of Colorado. He is a nationally certified tobacco treatment professional with over 15 years experience in public health. Most of his efforts are focused on providing health systems technical assistance for local, regional, and state governments and their partners in community behavioral health centers, justice-involved agencies, and medical services. So Jim, thank you so much. We have met him, you know, a while ago, Tiffany and I, and just really excited to hear your presentation and what you're going to bring to Virginia as far as how we can really make this a priority for us. So thank you so much, Jim.
Absolutely. So I, excuse me, I do have a lot of, I'm going to go ahead and share my screen. Duh, here's the thing that I have to do. I do have a lot of material, so I'm going to jump right into it. I did start with a picture of me. I had that haircut for 25 years before I decided to grow it out. So first professional haircut in 25 years was just a couple of weeks ago. All right, so today I am going to be talking about the sort of the intersection of what we call behavioral health and tobacco, right? But when we talk about behavioral health, we're really talking about two broad groups, one of which is the mental illnesses or mental health on one side, and addictions to alcohol and other drugs on the other side. And I don't really like to consider these to be one big group. I really don't even like to consider these as sort of even two big groups, because within mental illness, we have a broad variety of different symptomologies. And of course, addictions to different drugs will manifest in different ways. But there are reasons that we do this. And so what I'm showing here in this sort of truncated fashion is that the relationship of tobacco use with mental illnesses is often complex and bidirectional. I'm going to keep saying complex a lot. Tobacco use precedes the development of anxiety, depression, first episode psychosis, and other mental illnesses. And acute episodes of various mental illnesses exacerbate and maintain tobacco use, with stress being an important and independent mediator. Causality is hard to determine in this space. So whether we think of these relationships as being causal or merely contributory or purely associational is largely still being determined. We have some evidence that some of these things are in fact causally related, but when we're talking sort of broadly about mental illness, it's just sort of easier to keep in your mind that it may or may not be. The relationship between, make sure I can do this, please go forward, there we go. The relationship between tobacco use and problematic use of other drugs, including alcohol, are similarly complex, but the relationship is normally more straightforward. If for no other reason than addiction is, for the most part, the one thing and not multiple things. But because it takes a few years from initiation of a drug to develop into a diagnosed substance use disorder, and experimentation with alcohol and other drugs normally follows experimentation with tobacco, it's, again, hard to know if tobacco causes other drug use or if their temporal relationship is observed merely as a consequence of the combined attributes of tobacco's availability when people are young and the natural course of a developing drug habit. There's a lot of reasons that we suspect a causal relationship in this space, mostly because we know that the misuse of one drug will prime the brain for future addictions to other drugs. But it remains the case that 88% of individuals who are daily smokers as adults began their habit before they were 18, and 99% started before they were 26. So regardless of whether you completely accept the so-called gateway theory of drug experimentation, use, and abuse, it remains the case that a nicotine habit is almost always already established when problematic use of other drugs begins. There is decent evidence, as I said, that at the very least, misuse of one drug helps to maintain the misuse or abuse of other drugs. So as I already mentioned, I'm not really comfortable talking about these two really big populations as if they were one. However, overlap between the two is common, and many data collection sites like psychiatric facilities often fail to differentiate or control for the conditions. And ultimately, they share overlapping risk profiles, which we'll talk about, and they require, broadly speaking, similar treatment approaches. In 2020, the National Survey for Drug Use and Health, I keep looking off this way, I apologize, that's where my slides are, so I need to make sure that I'm saying the right words. In 2020, the National Survey for Drug Use and Health estimated that about 38 million adults had a substance use disorder. Now, I'll sometimes say misuse or abuse or dependence. In this particular case, I'm talking substance use disorder, the DSM-5 criterion selected mental illness. That works out to almost exactly 18% of the adult population. 38 million adults works out to about 18% of the adult population. And 53 million adults had a mental illness, and that's about 25% of the population. And again, on mental illness, it's abbreviated on this slide as AMI. That's the SAMHSA terminology. That's any mental illness. And we'll talk about some of the breakout mental illnesses. But again, I know some people are more comfortable with saying mental health, but here we are talking about diagnosed diseases as per the DSM-5. So that's about 25% of the population with an ongoing or recent diagnosis. So by contrast, that number that had both from that previous slide was 17 million. So that works out to about 32% of individuals with any mental illness also having a substance use issue, and 45% of those who had an SUD, or 45% of those with an SUD also had a comorbid mental illness. Researchers have discovered that whatever the dependence rate in one population of users, it is often higher in populations where the baseline prevalence rate is higher. So just to be clear, not use, right? Researchers have discovered that whatever the dependence rate is in any given population of users, that dependence rate is often higher in populations where prevalence is higher. And therefore, while the percent of individuals who are dependent on tobacco in the general population could be as high as 90%, depending on what your criteria for dependence is, it could be and is almost certainly higher than that among the behavioral health population, where prevalence rates already are 2 to 3 times higher. We need to understand that nicotine dependence is not some sort of ignorable or exaggerated myth. It's a critical component of our work. Nicotine is more addictive than any other drug of abuse. And while every drug dependence is unique, all dependencies fundamentally share one trait in common, and that is that they impact the brain in such a way as to simultaneously and separately encourage future drug use, and while depressing the ability to, they also depress the ability to choose not to engage in future drug use. Those are separate mechanisms in the brain, one that encourages drug use and a separate one that would inhibit that behavior, which is then suppressed, okay? Dependence is a doom loop, trapping individuals in a cycle of use, withdrawal, drug seeking, and use. It's not impossible to overcome this damage and escape the doom loop. However, nicotine is unique in a lot of ways, and one of them is that individuals are unlikely to simply quit on their own. Nicotine recovery requires access to and the use of evidence-based treatment, not educational brochures, not squeeze balls and mints. Our gold standard of care for nicotine dependence is medication-assisted treatment, right, and counseling. The combination of those two things increases the odds of success 500%, from 5% without assistance to 30% with it. And nicotine dependence, even in the general population, these are general population figures on this slide, is quite high. By the most conservative estimate, about 50% of tobacco users would have qualified for an official diagnosis using DSM-3 criteria back when that was our standard. And depending on how you measure dependence, it actually can go quite a bit higher. We know that historically, about 70% of current smokers want to quit. Right now, when we ask them, about 70% would say they want to quit, and that 55% of smokers will try at least once in any given 12-month period, and most of those will not be successful. And to me, that's a good enough criteria for dependence. That's not what the DSM-5 says, but that's what I say. The American Academy of Addiction Psychiatrists and the author of the book Golden Holocaust both put that number between 60 and 80%. And over 80% of smokers express discontent at their inability to quit. So that's criterion 1. So even by the DSM-5, just being unable to quit, it works as 1, and you need 2 to qualify for a diagnosis. And in this case, the discontent at the inability to quit is normally accompanied by either reports of lower health or a fear of contracting a tobacco-related disease, and those become second criteria. So at that point, it is possible that close to 82.4% would actually qualify for a diagnosis of tobacco use disorder, according to the DSM-5 TR. And then, of course, we look at regret at having started the habit, and that regret is often following quit attempts that failed. So we're looking at up to 90% of current tobacco users who are expressing regret at having ever started the habit. So as I continue going forward, I want you to try your best to hold, I say 4 or 5 things. The last one's just sort of a tag on. So 4 things in your brain. And because these 4 things really govern in varying degrees almost everything that's going to follow. And the first thing is that we need to understand that nicotine dependence is an extremely common co-diagnosis across mental illnesses and use disorders of other drugs. And despite, maybe even because of this level of dependence, individuals that are receiving services for other mental illnesses and substance use disorders want access to nicotine recovery services. And this is going to become important later. I know somebody had asked about whether or not we can or should be incentivizing tobacco cessation recovery. And the fact of the matter is that don't necessarily need to be, because these are already desired services. It's a sort of a myth that they are not desired. Because they want these services, and because such services can deliver improved health and improved quality of life, as public health employees, as behavioral health professionals, as policymakers, as good friends and family members, we have an ethical obligation to make sure that individuals who want these services have access to them. And finally, we need to understand that with proper treatment, cessation is absolutely possible for these populations without undermining other treatment goals like mental health or recovery from alcohol or other drugs. And sort of the fifth thing is that just a reminder that by proper treatment, we do mean evidence-based treatment. So really try to keep those four things in mind, because that is the linear argument for why I think this is so important. So I've already mentioned that individuals within the behavioral health population have disproportionate prevalence rates for tobacco use, and I've implied that the mental illness or substance use is a fundamental driver of that disproportionate use, those higher prevalence rates. But there are other factors that may be contributing as well. But before exploring those other factors, I want to point out that the really key outcome of this level of use, right? It's not just the case that behavioral health populations have a higher prevalence rate. I mean, that is the case, but it's not just the case. It's often the case that each individual in these populations uses more tobacco per person each day than the average person in the so-called general population. But even still, we're not really to the problem, right? Because the problem is not merely that they, quote unquote, use tobacco. It's that tobacco is so very dangerous, right? The real disproportionate burden of tobacco use is not the use per se, but rather the additional risks posed by that additional use. I just want to keep that in mind, because sometimes we concentrate on prevalence rates, and I'm about to concentrate on prevalence rates, and I want to hold in mind that what we're really trying to do here is save lives, okay? So it is hard to disentangle educational attainment from job opportunities, and it's even harder to disentangle either of these from poverty. But when we look at poverty and smoking rates, we can see a clear linear relationship between income and smoking prevalence rates. The mechanism for this are probably multiple, but well worth keeping in mind. And also worth keeping in mind is the role that mental health plays in being a productive and happy worker on the one hand, and an absent or dissatisfied one on the other. And I don't mean that that's not a call to place the burden of being happy on the employee. It's just to note that poor behavioral health often has the effect of limiting employment and income opportunities. And so the relationship is, once again, best described as complex, with behavioral health impacting income and tobacco use, with income impacting behavioral health and tobacco use, and with tobacco use impacting behavioral health and income. All those arrows go in all the different directions, basically. Similarly, being under or unemployed is going to reduce the chances that one has a robust insurance plan. This is going to have a lot of effects. Insurance is insurance. It offers security. One of the best and most interesting and most robust findings out of the Oregon Medicaid lottery studies is that even without using primary medical care, emotional well-being goes up just when individuals were enrolled in Medicaid. People can't access tobacco cessation benefits that they don't have. Having a robust insurance plan that covers tobacco cessation improves access and affordability, making those who have insurance more likely to quit and making those without it less likely. Individuals in low-paying jobs or who are unemployed are also more likely to live in subsidized housing. And as many of you probably know, subsidized housing now comes with no smoking clauses attached. And while this kind of policy hopefully acts as encouragement for residents to quit smoking, the reality is that until they do, they also serve to increase housing insecurity by raising the risk of eviction. And as housing insecurity goes up, so do prevalence rates, with individuals experiencing homelessness smoking at 4 to 5 times the rate of the general population. And all of this additional burden, all the things I just talked about, is something that smokers suffer even before they begin to develop any of the many tobacco-related chronic diseases, which are not just heart disease, right? I showed the slide a minute ago. It's lung cancer, it's COPD, it's stroke, it's diabetes, and others. And all of the risks to all of those things increase when individuals are sedentary. And being sedentary is a very common side effect of many of the medications an individual with a serious and persistent mental illness may be prescribed. So with all that in mind, my director calls me the chief pessimism officer. So not a lot of great news here, but let's look at least a glimpse of some good news. So what is our increased risk of prevalence look like? I've said increased prevalence over and over again. So I use this graph here to suggest that our problem, or that our policies have in effect left behavioral health populations backward in time. So you can see here that while only 13% of adult smokers in the general population, you can see that 13% of adults are current smokers, but 32 to 60% of individuals with anxiety smoke. This effectively leaves them in like 1981. And between 34 and 80% of those with alcohol use disorder smoke, leaving them in effect in 1979. And there are comparable figures that just go up from there. Depression, ADHD, PTSD, other drugs of abuse, bipolar disorder, and of course, schizophrenia is just literally off the chart, off of this chart. So how does this happen, right? How does the prevalence rate in the behavioral health population get so high? And we can talk, by the way, about why those ranges are so big on that previous slide. So I normally think of 5 separate mechanisms. I'm not going to talk about all of them. I don't have time, but I'm going to talk about 3. And the first major source of these different prevalence rates is specific tobacco industry targeting. In some cases, the tobacco industry specifically went after individuals with mental illnesses. And this is what we saw when the tobacco industry began supporting the use of cigarettes as low-cost medicine for individuals with schizophrenia. On the one hand, they had a purely academic strategy, paying for research to confirm a potential, if marginal, therapeutic benefit to smoking for those individuals. But they also had a PR campaign, taking the research directly to psychiatrists and other medical professionals, working with those populations. And they had a so-called philanthropic campaign, providing cigarettes directly to psychiatric facilities. And then we have what is often referred to as increased need. That's a phrase I do not like. I would prefer to say that many individuals with a behavioral health issue often have shared childhood experiences. These shared childhood experiences are often called ACEs, adverse childhood experiences, like having lived in poverty, having one or both parents missing from the home, often involved in the criminal justice system. They may have suffered abuse or neglect, including physical, emotional, or sexual abuse. They have experienced food insecurity, even malnourishment. All of these, and several I'm not mentioning, are what we would call risk factors for initiating and experimenting with tobacco, or really all drugs, right? I have addiction there in the block. And these things are not just associated with the development of addiction, but also poor mental health, a higher risk of incarceration, and just poorer health overall. And again, these are all complex relationships with arrows running in every direction. So having a higher risk of incarceration is also going to be a risk factor for mental health conditions and addiction, and vice versa. So more often than not, the behavioral health population was just caught up in marketing strategies that were aimed at what I would consider behavioral health adjacent groups. And this is what I call the behavioral health net. So for example, the tobacco companies used and may still provide cigarettes to homeless shelters. And that's an area, that's a site, a physical site in the world where individuals with higher prevalence rate of mental illnesses occur, right? That's where they show up. The homeless shelters offer free cigarettes in order to entice individuals experiencing homelessness to come in for other services. And not all homeless shelters do this, by the way, but it's not an uncommon practice. Cigarettes are often touted as part of the culture of substance abuse, right? Substance abuse treatment recovery groups. And the tobacco industry has historically fought for Clean Indoor Air Act exemptions for places like casinos or jails, where again, a disproportionate share of those who are served are in the behavioral health population, right? So as we move into this next section, which is among my final sections, I want to leave you with this. Tobacco use, along with other drugs of abuse and or along with mental illness, is extremely common, but individuals suffering from these conditions want to quit. And that's the thing that I think that's the thing that I have, that's the difference of opinion that I run into the most frequently in these trainings. And so maybe you're already sitting there and you're thinking, no, that's just simply not the case. Well, it absolutely is, I promise. And in fact, they want to quit at higher rates than the general population, right? The general population. So you can see on this, you can see here in the gray and black, those who want to quit in the next 6 months in black, that's 40%. And within the next 30 days in gray, that's the general population figures, that's 20%, right? But in the orange and green, you can see the comparable rates among inpatient, outpatient, and depressed patients, and among methadone clients. And of course, that's not every single group within this, in these broad populations, but they're pretty indicative, and they sort of run the gamut between, just by including inpatient and outpatient, and methadone clients are really hitting high points across the board here. So, and in all these cases, right, the number who want to quit is higher than the general population, and sometimes like a lot higher. And although this may seem surprising or counterintuitive at first glance, we need to understand that use in this population is happening at a higher frequency. It's happening at a higher intensity and with higher volume. Therefore, all of the inconveniences and damages of a typical tobacco habit are worse. It takes more time out of their day. It costs them more money, and the physical toll comes from them faster. The average smoker is going to lose between 10 and 15 years of life due to their habit, but smokers in the behavioral health population may lose 20 or 25 or more. It's not uncommon to have them die in their 40s from tobacco, right? And so this slide shows the readiness to quit among 300 individuals across 7 residential substance abuse facilities that we were working with. These were actually 300 individuals who were court-ordered to substance abuse treatment. And here you can see that about 45% want to quit within the next 1 or 2 months. That's how we measured it. And another 9% had tried to quit since entering services. So they quit voluntarily before we even showed up to ask them if they wanted to. So that, which brings me to this point. I always like to point out that readiness to quit is an important reason to extend services to those people, the ones who want it. But it's also the case that extending smoking cessation services provides benefits to another group that we barely even recognize exists. And that's the non-smokers, who are often receiving services in the same places that have these high prevalence rates. In this sample, about 17% of those receiving treatment were ex or never smokers. And finally, although our time allotments were a little different than on the previous slide, those reporting no interest in quitting in the next 60 days, that's what we measured, is roughly equivalent to those not desiring treatment in the next 6 months on that previous slide. So in our case, that's about 35% of folks compared to the overall average on the previous slide of 29%. So these numbers are strikingly consistent. I just like this slide because I gathered this data, and it's always fun when your numbers like match the academic research. You're like, oh my gosh, it's the same thing. Anyway, so in addition to wanting to quit, one word of hope, and actually the reason that all the things I just said mentioned rise to the level of a moral imperative, is not just that the individuals in the BH population want to quit, it's also the case that they can quit. And the proper support, and with the proper support, their chance of success is nears, and in some cases surpasses, the chances of individuals in the general population. However, without access to evidence-based support, their chances drop precipitously, which is why I'm so happy that you're all here and that the attendance in this presentation is so high. Okay, all right. So in just a moment, I'm going to share the results of 2 studies that I think offer some insights into whether and how we should be extending tobacco cessation services to individuals in the behavioral health population. But before I do, I want to make clear that whether we're talking about mental health or substance use disorder, what we see, there's some myths associated with extending this service. And the short version is, the primary myth here is that individuals, when we take their cigarettes away, their symptomologies go up, their symptomatic expressions go up, and they don't, right? When we treat tobacco at the same time as we treat mental health, we actually see a reduction in psychiatric services. We see a decrease in hospitalizations. We see medication doses going down and achieving similar or better results. And we see that individuals whose withdrawal is treated are half as likely to leave against medical advice. And similar results show up in the substance use treatment world. We know that 75% of folks in these environments want these services, even when they are involuntarily forced into tobacco abstinence, nicotine abstinence. At discharge, 50% claim that being tobacco-free helped them in their recovery. Once again, we do not see a worsening of psychiatric symptoms. In fact, it's the opposite. We see improvements in psychiatric symptoms. And in addition to all that, we see a 25% boost to long-term abstinence from both substances when we co-treat. And actually, that's an average across different drug treatments. So we actually see a lower boost, but still a boost when we treat opioids and nicotine at the same time. And we see a significantly higher boost when we treat either cocaine or methamphetamine addiction at the same time as we treat nicotine. So the two studies that I want to talk about, this was one that we were a part of, Lukowski et al. 2015. This used data from from 6 states that National Jewish Health was running quit lines for. So this is a quit line based study, and the researchers asked an additional initial screening question, which was, do you have a mental health condition, yes or no? So I always like to think of mental health, the mental health population in terms of 3 or 4 tiers. The most obvious and significant one is what we'd call serious and persistent mental illness. Those are diseases like major depression, bipolar, schizophrenia, schizoaffective disorder. And then we sort of the next down block are the people who are receiving inpatient care at some point for any mental illness. So they have a diagnosis and they're typically admitted into a hospital for some length of time. Then there's like your outpatient population. So again, these are individuals with a diagnosis, but they're living at home, they're living in the community, and they're coming in for treatment on, say, a regular basis. Or maybe they're not coming in for treatment, but they are on medications, that kind of thing. Their condition is controlled but diagnosed. And then there's a pre-diagnosed or not undiagnosed population, individuals living in the general population who nevertheless have a condition that maybe prevents them from going to work as regularly as they want to, or something like that. And so that's this population. That last one is this one. The quit line just simply said, do you have a mental health condition? They didn't ask for a verification of a diagnosis or doctor's order or something like that. So after 6 months, I'm sorry, this was a year. After a year, 43% of those going through the quitline program claiming to not have a mental health condition, 43% of them were still abstinent from nicotine. In those claiming a mental health condition, 33% were tobacco-free. Now, keep in mind, these were identical services, and at 33% success, that's still an extremely high number. That's a really great cessation rate. Lower than the quote unquote general population, the no mental health population, but still pretty good and roughly comparable. They asked a second question though, and I think this is really interesting, and that was, do you think your mental health condition, of course this was only asked of the orange bubble people, do you think your mental health condition will impact your nicotine recovery, yes or no? So the people at the top said, no, I don't think it's going to impact my recovery, and the people at the bottom said, yes, I do think it's going to. And you can see that just the confidence that it would or wouldn't impact their scores or their recovery did, right? So our baseline 33% for the entire group goes up to 35 for those who claimed it wouldn't interfere. So in fact, barely did, and among those who thought it would, it did. So which is to say that this could be just an accurate reflection of their knowledge of how important their mental health condition would be in their recovery effort, or it could just be that if you believe that that it wouldn't influence you, it doesn't. So we can just see here that 35 points is 8 points lower than the non-mental health group and 9 points higher than the mental health plus interfere group. Big takeaway here, and I'll say this again on after the next slide too, is same levels of service. At the same levels of service, we do see disparities, but we still see that what they did for the first group also worked, quote unquote, worked in the second group, just not quite as well. So we want to adjust that up, right? The second one was from an HMO in Israel. And this was a screening group and then connection to services. And you can see just from the captions on these bubbles, these were individuals with a diagnosed serious and persistent mental illness. So typically medicated, but they were talking about bipolar, schizoaffective disorder, psychosis, those sorts of extremely serious persistent mental illnesses. And once again, with the same sort of program in place for both those with and without SMI, we see that 27% were still absent. And I think this was at 6 months, but I'd have to double check that. At 6 months, 27% were still abstinent from nicotine, and that's without an SMI, and 20% with an SMI. So these numbers are actually pretty close. And again, 20%, pretty good cessation rate, all things considered, especially for this particular audience at the same levels of service. And I keep saying same level of service here, but we actually have a problem. And that's this. The most significant predictor of cessation in these two groups was whether or not the person used medications. Medications in this particular intervention was optional, but that option was not offered as frequently to individuals in the SMI population. So here we have a situation with pretty good abstinence rates among individuals with SMI, despite the fact that they were actually offered a lower intensity service. Okay, and that's going to be our key takeaway. The question was, how do we treat tobacco cessation in this group? And the answer is use the same approach that we use for everybody else. This is what I have on the board here is gold standard care. This is the top line service and it works for everybody, but higher need, higher intensity of dependence, higher need is going to require us to respond in kind with higher intensity service, right? So what we're going to do, right, is hopefully everybody knows what the 5 A's are, but if you don't, that's okay. If you don't know what the 5 A's are, if maybe you know what SBIRT is, screening, brief intervention, and referral to treatment. And if you don't know what either of those things are, please reach out to me. I can hook you up with some resources. So we're going to use ask, advise, assess, assist, and arrange to figure out what the nature of this person's relationship with tobacco is, and we're going to direct them into the 7 USPF, the United States Preventive Services Task Force, can't do the acronym, evidence-based standards. All these services here at the bottom have received a grade of A from the United States Preventive Services Task Force. They work, right? Telephonic counseling is your fancy word for quit line. Then we have group support, individual counseling, peer support, which is often really overlooked in this space. And always like to reframe the use of nicotine replacement therapy, bupropion, and varenicline as MAT, medication-assisted treatment, because in other drugs of abuse, we're always talking about MAT. We're always elevating MAT to the gold standard of care. We talk about it in these high and elevated terms, and we need to extend that same sort of language to nicotine replacement therapy, varenicline and bupropion. Smaller services, busier clinics might have to default to the ask, advise, and refer. And just as a crosswalk, these two things, sometimes that graphic implies that screening, brief intervention, and referral to treatment, aka SBIRT, is the same as the 2 A's and an R, ask, advise, and refer. But really, I'm trying to draw the parallel between SBIRT and the 5 A's, the full 5 A's. In any case, no matter what we use, we're going to make sure that we are assessing appropriately, and sometimes that involves a little bit of what I would call assist, to drive them into the appropriate treatment. And then we want to make sure, especially with our mental health and SUD clients, that we're making sure to really enforce that continuity of care, that really making sure we're following up with our care team, treatment team leaders, and figuring out where this patient is as they go forward, and modifying our treatment up and down in intensity to meet their ever-changing needs. So I keep hitting on this higher level of nicotine dependence driving higher intensity treatment. So that's an important takeaway from this. Another big medical or myth busting exercise is there's always this concern that we should delay or postpone, perhaps indefinitely, inserting medications into our behavioral health clientele. And we absolutely should not do that. There's no reason outside of like normal medical considerations that we would just sort of blanketly say that for BH pops, we shouldn't do this, right? I mean, there are certain drugs with contraindications. Bupropion, you can't prescribe to somebody who is at increased risk of seizure. So individuals in the early stages of alcohol recovery, alcohol dependence recovery, they're already at higher risk of seizure because of the nature of that withdrawal, and therefore they would not qualify for bupropion. So I mean, but that's a bupropion thing. That's not a behavioral health thing. And also nicotine replacement therapy, individuals who use nicotine are already getting nicotine. So to transfer them to NRT is just 100%. No one should say 100%. It's 99.9% safe. We do want to make sure that in situations where somebody is going inpatient, they're going into a tobacco-free environment, that without something like nicotine replacement therapy, they are going to go into withdrawal. We should consider that unethical the same way that we would treat any forced withdrawal as unethical, and we should be treating withdrawal as people enter these therapeutic spaces. That's for their benefit, and it's also one of their fundamental human rights. And then finally, just another point of myth busting is that there was a black box warning on varenicline that indicated that it may, in some people, cause psychosis, aggression, suicidality. But that, after one of the largest, if not the largest clinical trial ever undertaken on a specific drug, they have removed that black box warning. Some of those things did occur, but they did not occur at any higher rates than they did in the control arm of those studies. So it simply is not the case that varenicline causes those particular conditions. So we should, and in the various medical establishments, the American Thoracic Surgeons Academy, College of American Thoracic Surgeons, I forget the name of the group, American Pediatrics, and American Academy of Family Practitioners have all moved to treating Vernon Clean as first line tobacco treatment. And finally, just a couple of things I said at the very beginning, that with proper treatment, we can actually surpass expected values of cessation treatments in the behavioral health population over the general population. And these are some of those studies, which is not to say that anybody should aim for these in their program design. These are extremely high for the populations, but they're, it's just to show you that I chose 2 studies where the success rates were still lower because the intervention was standard care. But if we actually really ramp up services, we can see, 38% is just a off the charts level of success. And I think that's my final slide. So now I don't know how long I talked. I hope there's still time to answer questions.
Yes. Hi, Jim. This is Nicole. So yes, you left plenty of time for questions, so no worries at all. Thank you so much for your great informational PowerPoint. I'm still kind of digesting everything, so let me take a minute to figure out how
I talk fast and I shove a bunch of stuff in there. You can digest it later. You guys are going to have the slides. You don't need me around for that.
Yeah. I think, what really came out to me was I didn't realize that big tobacco actually gave cigarettes to psychiatric facilities and homeless shelters. That was something I was like, oh man, I did not realize that. And so that kind of, it's just very interesting to see the history of big tobacco and how they've influenced, certain populations. And now, on this side, we're kind of seeing the effects of it. And it was great that you said, just to be able to make sure people have insurance, to have the access to those services, I think was really smart, because that's really kind of where it starts, right? And also you talked about these facilities, to make sure they have, tobacco treatment. Like our first question, how many states require that? Only 5, out of the whole country. And like you were saying, just making sure that this population has the access to these treatments because they want to quit. So I think that's really great message out of, anything at all. So to kind of go back, I know you mentioned one of the questions someone asked was, are there any incentives to stop smoking? And you mentioned, there shouldn't have to be incentives because people want to quit. So I guess going to another question was, where was it? It was, how do you get behavioral health organizations and treatment facilities to engage or to kind of incorporate and understand the importance of tobacco cessation and treatment when it isn't required? How do we stress that to them that they need to make sure they incorporate this in their services?
It's a wonderful question. I can do a whole day on it.
I'm sure.
Whenever you're trying to persuade anybody to do anything, there's a couple things that sort of sounds like I'm like some sort of magician. Like I'm a mesmerist. I can persuade anybody to do anything. I absolutely cannot. But some things that you have to just kind of keep in mind is, first of all, don't assume a dearth of knowledge. It's normally not an educational solution. We have this belief that we are perfectly rational people, and all the things that we think or believe are the result of our our deep thought and consideration, and that's just not the case. It's not the case for me. It's not the case for anybody on the line. And so the same thing's true for them, right? It's not that they don't know, right? Because that's the strategy. Well, if they only knew what I knew, then they would believe what I believe. Don't assume that. It's normally will. It's normally just, and I know that sounds weird, but most people, to use like your motivational intervention language, in the context of tobacco cessation, offering tobacco as a service, just going tobacco free, most people who are in charge of, say, a community behavioral health organization, they know tobacco is not great, right? They know it's harmful to their clients. They know that stuff. But, and they know it's good, but. And we just have to figure out like what those buts are for them to start, and just use our motivational intervention tactics to get them to see and weight more heavily the first part. They know it's good. So what are those things that are standing in the way? And a lot of times they'll go to finances. And this is one of those situations where the answer really is in the education, but they're not going to believe it. Right? We know that they're going to say, well, I'm afraid that if I go tobacco free, that we're going to lose our census. right? People are going to go seek services somewhere else. Now, we've seen this, me specifically, and then the academic literature separately. We see this over and over again, that is simply not the case. Sometimes there's a little bit of a hiccup, but normally census gravitates right back to wherever it was, because what they're not seeing is all the people who aren't going to services there because they allow smoking there, right? And those people show up even if they lose some people who absolutely insist on being able to smoke. But even among those clientele, and that's why I share this data that I did, even among the clientele they're serving, they already have ex and non-smokers whose rights they're violating, whose treatment they're hurting. And we need to expose those people and elevate them. So anyway, first, just figure out who you're talking to. And then figure out like what it would take to bring them over the line. In terms of like finances, we already know the census doesn't get really impacted. We actually know that in addition to the census not going down, we also know that there is eventually a return on investment, right? Like whatever money they put into going tobacco-free, either from the services path or the tobacco-free spaces path, they're going to start seeing money come back in terms of employee productivity, lack of sick days, patient satisfaction and returning. Like there's all sorts of ways in which the ROI is there. Generally speaking, we just need to help them emphasize what they already know to be true. So what we do, that's a long-winded answer, is we look at their mission and values. This is what I do. I go to their website. I go to their mission and values. If they're a nonprofit, I look up their board members and I look for spaces that are sort of outside the organizational structures itself, right? And then I bring those into the conversation. I'll be like, hey, your mission says that you're here to do X, Y, and Z. It says your values are A, B, and C. Tell me how allowing people to smoke is in line with that mission or values. And then they know. They know. Here's the other thing too. So this is one more quick answer to this. Change is hard. And somebody asked in the pre lineup, do I have any good examples? I have a really wonderful example. I love this example so much. We helped an organization here in Colorado. They were moving sites. They were making a huge expansion. So this is a great time to do a big change, right? And so the president, he was outgoing president. So, you know, he wasn't have to live with this situation. He's like, we're going to go tobacco free, but we're going to do it in the crisis center first, because the crisis center was getting a brand new building. And in most behavioral health organizations, the crisis center is the one they want to do last for obvious reasons, right? But because that was the one that was changing, that was the one getting new building, new staff, all this stuff. He's like, this is the one. So they went tobacco free. They were patching people as they came in for services. And about 12 months later, we heard a rumor that things were on shaky grounds. So we called them back up. We're like, how is everything? And they told us all the things they're dealing with. And we said, that sounds really bad. Do you guys want to like try again? Like we'll put smoking back in, we'll make sure it's allowed, and then we'll work on a new plan. And they said, absolutely not. Right? And they stuck with it. And I'm happy they did, but it's also a real clear indicator that it's change that's hard. It doesn't matter which direction that change is going. If you have to consciously make the decision to go to get better, or in this case, to get worse, the default position is to not make that change, right? How do we make change easier is the question. Change is always going to be hard. How do we make it easier? And the answer is whoever's helping with that change, whoever that change manager is, whoever that leader is, whoever is the face of the change, they have to be trustworthy. They have to be able to convince people, I can see this through to the end. I can get us to the point where the census rebounds. I can get us to where the ROI manifests. I can do that. I have the skills. I have a demonstrated pathway to success. Trust me. And if you can instill trust, they will give you that responsibility. It's like it's like wave a magic wand and just be trustworthy. But that is in fact the answer.
No, I like
I mean,
that.
honestly, that's why organizations like mine exist, right? Like when I go into these organizations and try to help people do tobacco-free policy, for example, they have massive amounts of skill, right? These are managers in that building. They know how to do this, but somebody, normally leadership, doesn't trust that they have the ability to do the tobacco-free thing. So we come in to say like, well, we're voices of authority, right, and legitimacy in the tobacco-free space, so they can outsource the trust to us. But it doesn't have to be that way. We can train people up anyway. But that's the whole thing. It's just trust, essentially.
Yeah, that's true. I like your answer. It wasn't the, traditional kind of answers we get, but what you said, I think were very tangible. Like, it's something, the way you broke it down, I was like, yeah, I can do that. Or it just makes sense. Like change definitely is hard. I think the ROI thing is very important because I remember when Dan Brown, I forget what state he's from, but he runs a casino and he was making it tobacco free or smoke free, I think. And I remember one of his worries, I guess the team was, are they going to lose people? But then he said, eventually, I mean, at first I think they lost some customers, but right now they're making more than they did before they had the policy. And there were people from other states coming to his casino because it was smoke free. So I think in any, I guess, business, even restaurants before, it's at the end of the day, you have to think of the long game, not just immediately after.
Well, from a business sense in casinos, I get why casinos want to stay allowing smoking, right? But they really need to understand that worst case or best case scenario for them, 45% of their clientele smokes. And that's an extremely high number, but it's still the minority of people altogether. And they've been catering to this expressive minority for a very, very long time. And they don't understand that, like, smokers can be in non-smoking spaces, but non-smokers have a real hard time being in smoking spaces that are that intensely smoking. So they're driving out 55% of their potential clientele every single time. And that's a minimum number. In most places, it's a much higher. Like in most geographies, no more than 12 or 15 people smoke, 12 to 15% of smoke. So they're losing a potential 85% of clientele. And that's just, it's an absurd decision making, and they all see it. All right, this is not like, normally I'd be like, well, I've never run a casino, so I don't know what I'm talking about. But this is a situation where every time a casino opens up, it becomes a tobacco-free space, they're like, oh, we're making more money than we used to. Like, yeah, clearly.
Definitely. I think we might have time for one more question. Let's see. Oh, what's a good one? I think people had some really good questions. I'm trying to pick one more. And you had an example already for what happened.
Since you guys are, well, so while you're looking for a good question, my colleague and I put together a 3-webinar series on working with community behavioral health organizations. The first one features our regional SAMHSA director, who just kind of does an introduction to like the federal and state level environment, mental health treatment environment. So how does funding work between the federal and state levels? And then the second 2 is the development of a model, the third of which is like 5 different case studies. So if you are thinking about like, this is what I want to do, I want to engage in my CBHOs, go check those out. There's a lot of great information in those, and they're free. So, just they're on our website.
Perfect. We do have one question from the Q&A from Jane Flowers. Used to be our manager for tobacco control program in Virginia. And she was saying that you had a very good point about MAT versus NRT. Could you repeat the part about providing NRT when going to a program where tobacco use isn't allowed? That is something we all should be using as a talking point.
See if I can find that question. Can you repeat the question while I find it?
Yeah. Can you repeat the part about providing NRT when going into a program where tobacco use isn't allowed? That is something we all should use as a talking point.
Absolutely. And my director, who is a psychologist, Dr. Chad Morris, he's much more adamant about this, because I don't feel like I could just tell psychologists that you're being unethical, and he's free to do that. But that is his line. He thinks that if we force people into withdrawal, which is a situation where they are going to suffer, even if it's just a little bit for a short period of time, that's just unethical. We are inducing a harm. Anybody who forces withdrawal is inducing a harm. And so that is not our charter, it's not our mission, and it's just antithetical to basic human rights. So if somebody's coming into a treatment space and we know that they are a smoker or a tobacco user, so they'll be going into withdrawal, then we should be proactively treating that. So whatever that means. So now some people are coming in highly agitated states. They might be coming in unconscious. And so we can't screen them for tobacco use. But as soon as we discover that they are in fact a tobacco user, that they are in fact suffering from withdrawal, then we should be applying nicotine replacement therapy or some other medication. It's just that NRT is just, they're already getting nicotine, and that's the active ingredient in NRT. So we know it's a safe transition for literally any tobacco user. So yes, and this is the model that hospitals use. Are you a smoker? Yes or no? They say yes. We slap a patch on them, and then we wait. And we can. There's no reason not to do this in any community behavioral health center or behavioral health setting.
Definitely. Thank you for repeating that. And right now we have 3 minutes left, so I'm going to kind of hand this over to Gina, kind of wrap everything up. But thank you so much, Jim, for your great comprehensive
fun.
answers to these questions.
Thank you. Yes, thank you, Jim. That was very enlightening. One thing I got out of that, I think your first key points, many things I got, but we have an ethical obligation, right, to provide the services to this population, and they want to quit. And we know what works, medication and counseling. So I think we have our path. We just need to take it and really focus. Loved your answer to how we really get behavioral health facilities to address this issue and make the change. So thank you so much. So we will continue on with this fight, because I think we do have a lot of work left to do in Virginia.
Well, thanks for having me.
I do want to invite you all to our webinar in October the 18th. We're excited to have Dr. Jillian Schauer, the Executive Director of Cannabis Regulators Association, and Sean Casey, the Senior Policy Manager with the Virginia Cannabis Control Authority, with us at our next webinar. And they will present information on cannabis, legalization of cannabis in Virginia, and the overlap between tobacco and cannabis. So I know that has been, top on a lot of people's minds as we move forth to legalization in Virginia. So I hope you can join us. Please share with your colleagues and send an invitation to them once you get your invitation. This webinar has been recorded. You will receive this as well, and please forward to your colleagues so that we can start the conversation and get the work done in Virginia. Everyone, thank you again for joining us today. Enjoy this Thursday, the first day of fall. Get outside, enjoy some cider, get some pumpkins, look at the beautiful color, and we will see you back here in October. Have a wonderful day. Bye.